Edward Norton, economist and co-lead of the pilot course for CAPRA, and pleased to welcome you to this first seminar for our new seminar series, part of our CAPRA curriculum, which is new in cycle 2 of our CAPRA funding cycle. The goal of the seminar series is to help population-based researchers in the ADRD space, and it will be a 2-year curriculum, and we have listed here upcoming sessions, 1 per month, and hope that you all be able to attend those. All of these seminars will be recorded, transcribed, and available on our CAPRA website. And because we are recording, we ask that you hold questions and comments till the end of the presentation. There will be a Q&A session, so you can raise your hand either in the room or online. And without further ado, I'm very pleased to introduce Dr. Julie Bynum, who will be speaking today on Medicare data for dementia research, basics, nuance, and access. Dr. Julie Bynum is the Margaret Terpenning Professor of Medicine, Division of Geriatric Medicine, and Director of CAPRA. She's a research professor in the Institute of Gerontology, a member of the Institute for Healthcare Policy and Innovation, Vice Chair for Faculty Affairs. She received her medical and public health degrees from Hopkins, further training at Dartmouth, back to Hopkins for additional specialty training in geriatric medicine. And here at Michigan, she leads interdisciplinary research teams to study questions about the complex drivers of quality and cost for older adults and how to improve healthcare policy and performance using national administrative data, which makes her the perfect person to talk about Medicare data for ADRD research.
Thank you, Edward. Thank you for here with us today. We're excited to have the renewal of our CAPRA grant, and I'm very excited to launch this first of the seminars. For many of you, this will be old information, or at least some of it. Hopefully there's something in here for everyone. So let's get started. That little figure over on the right with all the light bulbs are my little way to remind you that I'm talking about a nuance as opposed to a basic. So hopefully it's just to help people understand where we are in the talk. So learning objectives for this presentation, there are 3. The first is to be able, all of us come out of here being able to identify the strengths and challenges when using Medicare data for dementia identification and dementia studies. The second is to gain insight to the test performance of different ways that we identify or the way we use claims to identify dementia cases. And the last is to understand how non-health factors influence the interpretation of Medicare data. So this talk is also in 3 parts. First part is sort of the general Medicare basics. The second part, I'm actually just going to share some of information from publications we've done and some of the validations. And then the last part, there's a lot of data slides just to give you examples of the nuance of interpretation. And I'll close just with 2 slides about accessing the data and where one does that. So first, let me talk about what kind of data are we talking about. I am talking about what we call healthcare generated data. This is in the category of real world data. This is not data that's collected for the purposes of research. It's collected in the course of healthcare delivery. And in particular, what I'm talking about today of Medicare fee-for-service and traditional Medicare and Medicare Advantage. Of course, there are other sorts of healthcare generated data, whether that's commercial insurance, Medicaid, the minimum data set, which is nursing home, OASIS, and the other evaluations, and of course the electronic health record data. Each of them have their own special nuance, but today we're going to focus on Medicare as probably the most commonly used for a disease like dementia, which thankfully really mostly only affects older adults and not younger adults. Therefore, Medicare is a good source of data for studying people who are living with this disease. So what is Medicare data? Let's start first with what is Medicare. Medicare is health insurance provided as an entitlement to people over the age of 65 who have paid 4 quarters of taxes, and other people are eligible based on disability or specific disease who are not over the age of 65. But first, so this is federally provided insurance, and entitlement means that if you meet criteria, you get enrolled, you're in the database, but there are different parts of the insurance plan. So everybody is in one part of it called Part A, but the other parts you pay extra or have other features. So reason I say all of that, it means this is basically a registry of all people over the age 65 in the United States who meet the criteria that I have on the slides. Fundamentally, what is the data then? It is billing data. It is the records that are used to pay healthcare providers for the delivery of services, wherever those services are delivered, as long as they're a Medicare or Medicaid eligible place. So then, therefore, what's on the data? It's who's receiving the service, what service was delivered, why it was delivered, and who pays, and who's being paid. That's really important, fundamental, basic knowledge. And I think a lot of people who just touch Medicare data lightly maybe don't fully grasp or think about the origins of the data. And that's really the crux of all the nuance we're going to talk about here. So there's some real strengths based on what I've told you already about Medicare data. It's a near complete capture of people age 65 and older in the United States. It also captures people under 65. You'll know a lot of people will talk about that group, but they are not the whole population. It's a subset of people with disability. The other thing that's really nice, it's a federal data set. So all the data elements are uniform. All the healthcare systems collect the data uniformly. It's cleaned. It's used and audited for payment. Not every variable is audited, but the ones that are audited, you can be pretty sure they're paying a lot of attention to make sure it's accurate. And there's really not a missingness problem for all this stuff that we generally come across, at least in the fee-for-service side. In addition, again, because these are federal data sources, you don't have to go to every hospital and request the data or every clinic. You actually have a single place where one can request all this data. And because people have been doing research for a while, there are validated algorithms to understand things like what does it mean to see a congestive heart failure claim on whether this person really has congestive heart failure. And in our case, we're interested in dementia. But there's inherent weaknesses that we have to acknowledge. Those are that anything that influences whether someone uses healthcare can create inherent biases. So issues that are present in access to healthcare, for example, or equity issues in quality will be in usual care will be represented or sort of captured in this data just by who's in the data set and whose experience we're seeing. We need to understand the origins that I just talked about because those origins mean financial incentives matter for what show up in the data. And that's really important when we're going to make the correct kinds of inference from the data. And the last part is these data represent clinical practice. And in the context of dementia care, in particular, if we're thinking about diagnosis and how good a diagnosis is, the claims can only be as good as the clinical process and the clinical quality and accuracy of diagnosis, which in the case of dementia is really challenging. Even the research definitions are incredibly challenging. If you talk to somebody at the Rush group and they tell you about all the different causes of dementia that they see inside the brain of a person who is purported to have Alzheimer's disease, we recognize that our ability to make accurate biologically based clinical diagnoses and see that in the clinical venue is extremely limited. So therefore the claims really are limited as well because they really reflecting what the actual physicians and nurse practitioners and associate providers are putting on their records. So we're going to move into, I'm going to show you some examples of where these issues of incentives and non-health things influence diagnosis. And we're doing, again, this in the case of dementia, but it actually applies to other diseases as well. The first is providing evidence that the diagnosis we observe in the claims data may or may not be related directly to the true prevalence of disease. This is a paper that Matt Davis and I did a number of years ago studying the changes in billed diagnoses for dementia in Medicare fee-for-service from the period of 2004 through 2017. And what we're showing is that over that period, if you look at the blue on the figure on your left on the line chart, the two blue colors are the percent of people diagnosed with dementia with an Alzheimer's disease diagnosis claim within the last 2 years of life. We focused only on decedents because we think there were things happening at the early stages of disease that would influence this, but really at the end stage of disease, things biologically and clinically weren't changing. And those lines represent about a 36% increase in the rate of diagnosis between the periods of 2010 and 2011. The orange and the yellow are showing you the uptake of electronic health records. We were just trying to show descriptively other things that were happening at this point in time. The vertical lines show when the National Alzheimer's Plan went out and when people started talking a lot more publicly and openly about dementia. And the other line in 2011 is when CMS expanded the number of diagnoses allowed on a bill. And that seems to really correlate very nicely when we see this increase in diagnoses. So what that means when you look at the figure over on the right is this is showing you the percent of people by age who have a diagnosed case of dementia in the last 2 years of life. And what we saw again in this time period was if you use the one claim that was the old way of using claims diagnoses, the percent of people who died with a claim for dementia went from 30% to 50%. If you use a more stringent rule of 2 claims, it went from 25% to 39%. So really enormous increases of people, quote, dying with dementia if you base this purely on claims. The other thing that we did in this study that I think is important for those of you who are going to work with Medicare data is we looked at where the claims were coming from. So if Medicare data has different files for different kinds of service, it's like the hospital file, the MedPAR inpatient file for hospitals, SNFs. There are professional service claims that are in the carrier file. There's hospice claims and there's home health claims. There's also DME, which we're not showing here. And what the figure on the left is showing is that this is the percent of claims occurring, the percent of decedents with claims in these health services. And what you see that, in the carrier file, it was pretty flat, but something happened in the middle of the inpatient hospitals started billing this diagnosis a lot more. What the figure on the right shows is really, we said, who is getting a presence of a claim in only one file type? So you might think a person who has one claim in an outpatient visit and it never shows up in any other, it doesn't show up in the hospital, it doesn't, maybe those are less, either less likely to be true or also less severe or something that they're not in these other settings. And what you see over time is that when people have this diagnosis, it starts to appear in all sorts of different claims places. There's no reason to believe that the people in 2008 with dementia were using the health system differently fundamentally than they were in 2013. So it's really hard to say that this is something about the disease itself. This is about billing practices. So if you're interested in a paper that's about how billing practices affect lots of things, we also looked at how the characteristics of the people in the time period and what the health services look like at the end of life. So bottom line here is that things influence where in the records and how many times in the records and what type of record diagnoses appear. And some of the, this is just a bottom line slide to show you the difference between epidemiologic estimates of the true prevalence of disease versus what we see in claims. The data sources here are the top row is HCAP from the Health and Retirement Study published by Jen Manley in 2022. The bottom is the Impact Collaboratory data, which I'm going to be showing you more of, where we applied the Bynum algorithm, which we're going to talk about in a few moments, and show you the real differences. So epidemiologically, the prevalence of this disease is much higher than we see in claims, which speaks to what we all hear about underdiagnosis, right? We think there's more disease than we're seeing in claims. It's across the board, all ages, all sex, all race. There are some big groups that have bigger gaps. So for example, the difference between the Black rate in HCAP and in the claims is larger than the difference for Hispanics, for example, which suggests there's more underdiagnosis in that group. So the bottom line that I really try to stress when I'm a reviewer, if I ever review a paper that comes to me, when I see somebody talking about Medicare claims and talking about the population who has dementia, I will object to that. That is not the population who has dementia. What we see in claims is the population who've been diagnosed with dementia. And those are fundamentally different things, as this slide really highlights. Okay, so now I'm going to shift gears to be more about some of the papers we published specifically about diagnosis itself for dementia, not the generic sort of Medicare issues. This model that I'm showing here, citation is fall off, is from the Institute of Medicine 2014 report of sort of the framework for how diagnosis occurs in healthcare. There's the things that happen before somebody even engages with the health system. Do they think they have a problem? There's all the stuff that happens in the visits itself. This model is thinking about an outpatient visit. And then the stuff that happens after. Do you communicate the diagnosis, and was treatment initiated? And when we think about the case of dementia, there are many, many places on this pathway where there are barriers and things that influence the likelihood of getting an accurate diagnosis or getting a diagnosis at all. So just to call out some of them, there are some communities and ethnicities for whom there's a lot of more stigma attached, so people don't come forward. There are other ones who really perceive the change in cognition as normal aging. It's not a disease, so they don't come forward. On the far end, if on the clinical side, if we don't have something to do for it, we're probably less likely to look for it because, there's not the sort of subsequent visits and the, doing medications. And we saw some of this with the advent of drugs around 2006, that some of these diagnoses rates started increasing then. And then there's all the issues in making the diagnosis itself. I told you already, it's really hard. And this is where the accuracy of diagnosis comes in, that some of our tools we use in the clinical environment work better or worse in some groups because they were mostly developed in sort of white populations, and their applicability in the clinical setting may or may not be accurate. And also the availability of expertise, people who are really savvy about making this diagnosis accurately. So all of those things led us to do a series of papers about diagnostic accuracy. These papers follow on papers done, 15, 20 years ago by Taylor, on which the chronic conditions warehouse diagnosis algorithm and claims was based. What we were saying at this point was, look, clinical care has changed dramatically over the last 15 years for this disease. We need to look again to see how accurate claims data are, and do we need to change what we were doing? Because before this time, what the recommended algorithm said, just use one claim in 3 years. Which, if I see somebody and they tell me I'm their doc and they say I'm having some cognitive complaints and I'm worried about Alzheimer's disease and I bill it, and then I see them back and decide it's depression and it wasn't Alzheimer's, I can't undo that diagnosis. So that's a very low bar, especially with a 3-year window. And we wanted to see if that was still the right way to go. So that slide says just what I just said. We wanted to also, second part of that was to see if we use shorter time periods, what that meant for accuracy. Because many, many studies done in health policy or in pragmatic clinical trials really use 1 year of data, and data accessibility for long periods of time is not something we often have the luxury for. So we wanted to know the performance in 1 year. So I'm going to walk through these slides pretty quickly because they're dense and these papers have been published for a long time, but I want to give you the general gist of what we have done. I encourage you to go and look at these things if you have interest. What we did was first take the health and retirement study, and we used the health and retirement study as a reference standard as opposed to a gold standard. What we did was we were using the 2012 data, we used the people linked to Medicare claims, we constructed both 1 and 3 year reference periods. The 3 year was to match up to what CMS was already doing. 1 year was the proposed that we think we need in a lot of our studies. On the HRS side, I call it a reference standard, not a gold standard. Why is that? So they're not actually doing in-person evaluations. They're using a telephone-based modified TICS score. So they do a bunch of cognitive tests over the phone. It generates a score. If somebody has a proxy, meaning they can't do it themselves, the proxy is asked some questions. And those scores are put into an algorithm. The Langa-Cabedo-Weir method is what we use with cut points to say whether somebody has dementia or cognitive impairment, but not dementia, or is normal from the perspective of this study. So we tested 3 algorithms. I'm not going to go into the details of that. Again, look for the paper. The bottom line is that what we found was the chronic condition warehouse algorithm. I'm trying to see if I can get my slide to point at this. I cannot. Had a positive predictive value of about 54%. So positive predictive value, we think, is the meaningful measure for health services research. It means if I see a claim, what's the likelihood this person has disease? Any of the 3 algorithms that we tested were a little better, but not great. The 1-year algorithms got much better. So you can be much more confident than a flip of a coin that the person actually has dementia. What you see is you lose sensitivity. You gain specificity and you lose sensitivity because we're using less time and a more rigorous standard. I will just tell you the standard way is we reverted back to what's used for all other chronic conditions. We use 2 claims in the outpatient setting 7 days apart, or 1 from an inpatient setting, which is the standard for pretty much every other disease. The E&M, I was really interested if we get like a doctor or a nurse practitioner looking face to face with a patient, an evaluation and management visit, do we get even better performance, even better specificity? The answer was no. So we went, everything we do now, we use the standard algorithm. That standard algorithm, when we test it overall, like I said, has 70% positive predictive value, but there's some people in whom it's actually even better. There's lots of wide confidence intervals. We have sample challenges in all these studies. But if the person uses a proxy, an HRS, claims are really good. What is going on there, right? Like the doctor says this person has dementia and they have a proxy. My hypothesis is if that person can't answer a question for HRS, they also can't do it for their doctor. So their doctor's it's gonna hit you in your face that this person has a cognitive problem and requires a proxy. So we're more likely to see that. We also see better performance for people who are older age and people who are Black or Hispanic, but the confidence intervals there are really wide. So we then redid this study in a different cohort. We're considering this a gold standard, the Rush Alzheimer's disease cohorts, because they do an in-person evaluation. Dr. Bennett, who leads this, I've talked to, he says it's not really gold, it's kind of silver. So we can talk about that a little bit. But so basically the same design, we only tested the Bynum standard algorithm, as Ellen McCarthy named the algorithms. I did not choose to have my name attached to these, I assure you. And just to say the advantage of the Rush cohorts, these cohorts, people are seen every year instead of every 2 years in the HRS. They have in-person assessments, neuropsychological evaluation, a neuropsychologist blinded to all the sociodemographics, comments on whether there's the presence of cognitive impairment, and then a clinician reviews all the data and then makes the final clinical diagnosis. So we end up with dementia and mild cognitive impairment, which is actually a specific research term, whereas CIND is not, and normal according to this. Now, there are differences between HRS and the Rush cohorts and how they make these determinations that actually influence the prevalence assessments of the populations. That's a topic for another day. We chose the standard algorithm. And the bottom line here is the performance looks a little bit worse than when we did it with the HRS, but it's within the bounds of the confidence intervals. So we're seeing sort of a positive predictive values in the 60% range. Sensitivities are actually a little better in this data set, and specificity. I'll also say the Rush studies are not national. They're not national representative. They're regional, and they're much, much smaller. But this actually gave us some confidence that even in a different data set, we can understand how these claims. The thing we could do with Rush that we couldn't do with HRS is because it's more of a gold standard, we could dig into the false positives and the false negatives. In this case, when we're talking about false positives, so people where we get a flag that says they have disease when they don't, what do these people look like? Now look, small sample. But what we're finding is that these people are older, sicker, have worse cognition and more functional impairments, and they also complain a lot about their memory. So these people are not false positives in the sense that they're normal. They're not normal. They are actually quite sick on average. And the conversion rate to dementia is actually, the false positives, not all that much higher than other MCI studies. It's 16% and 30% over 2 years. So what about the false negatives? This is the underdiagnosis issue. And what we find here is that you see more missed cases in people who are non-white. Again, these numbers are tiny. And we see people who are less functionally impaired. So when you get a really robust neuropsychological assessment, somebody detects your cognitive impairment, they get labeled, but when you're in the clinical environment, you're not functionally impaired very much, you're less likely to get labeled. So in summary here, I'll just say, what do we take away from this? Sensitivity in claims is weak. We are missing people who are early stage very much. We are missing people who are in some racial and ethnic groups. Those are the two big areas where we see even greater missing of cases. But some subgroups are actually, if there is a claim there, they're more likely to be accurate. Older, use of proxy, Black race, more severe disease. Subjective complaints are really common among false positive. If you think about the clinical interchange, if somebody's complaining to me about their memory, I'm more likely to go looking as opposed to the person who does not complain. And I will say one of the sine qua non of Alzheimer's disease itself is lack of awareness. Real problem in a clinical setting. If there's lack of awareness that you have a problem, you're not going to self-report. It makes it much harder to make a diagnosis. I already said this, false positives are not normal functionally or cognitively, and the false negatives are more likely to be non-white and less functionally impaired. Just a couple notes. We do have a third paper examining the positive predictive value and diagnosis and claims in African Americans only in RADC. And we do this across the full time spectrum. So we can say in 10 years, how many people actually get a diagnosis in this group, because data goes back to 1991. Again, very small numbers. Right now, we're working on an MA study that will be coming soon. And we're also just beginning study on working on trying to understand when you use different reference standards, so if you use NHATS versus HRS versus RUSH, how does that influence various things of your assumptions about claims and their accuracy? Whew, that was a lot. I'm going to change gears now and start throwing some data at you. Actually, this is one more paper. I very recently presented this, so I'm going to go quickly through this because I think most people who are engaged in this seminar today actually have seen this data already. When we use this algorithm, we find approximately 7% of adults 65 and older have been diagnosed with dementia in the United States, but that percentage varies dramatically across the United States. This is the slide that shows that in the lightest areas, we're seeing 3.5% to 6% of people diagnosed with dementia. In the highest areas, we're seeing 8 to 13% of the Medicare population diagnosed. And we set out to do a study. Again, this was with Matt Davis and others to really unpack this a little bit. Because I think in the epidemiologic world, people think of regional variation to be things about risk of disease. It's the environment, it's risk factors for the disease. But I really sat on this data for a long time before I published it because I wanted to be able to show it's not just that. There's other things at play, some of the nuance that you guys all know about using Medicare data. So, why would you get differences? Well, there could be true differences in the number of people in that population, that epidemiologic sense, that there's true differences across place in the number of people with disease, whether that's from environmental risks, educational strengths and weaknesses of an area, population age. People in certain areas may not seek care. We already talked about that, right? So if that's the case, you can see differences. And then health systems are not uniform in how they perform in this area. And so uniforms may be more or less apt to seek out this diagnosis. So what did we do? I set out to do this paper and tried to convince Matt that what we need to prove to people in the Alzheimer's world, less so in the healthcare world, that this is not all about just disease. And that's what this paper, I think, really helped us show. What we did was we modeled, we took into account those population factors that would cause expected, warranted variation: age, sex, race, level of education, health status in the terms of smoking, obesity, and diabetes, which are risk factors, not using claims because that would be endogenous, but pulling that from other sources. We also put in diagnosis intensity, which we know already from other research places are more aggressive for looking for diagnosis. And what we found was there are places that diagnose more than we expect and places that diagnose less. what does that mean for individuals? We converted this into these figures, which show on the x-axis is showing if you live in a place with an observed or expected ratio, which is our diagnosis intensity measure, with lower to higher diagnosis intensity, your likelihood of getting a diagnosis in your claims doubles from the lowest to the highest. And it doesn't matter what your age group is or what your race group, it doubles for everybody. So some of those things that we know that are at play, race, healthcare seeking, this actually applies to everybody, which suggests to me this is something about health systems and what's going on across place. So that's our latest publications, and I think that's a combination of that's really the basics to understand. And now what I'm going to do is just show you some of the issues that will make you really, really smart as a Medicare investigator when you're working with your colleagues in this space for dementia. I had the good fortune to be the technical data core director for the Impact Collaboratory. If you don't know about the Impact Collaboratory, look into it. It's a large grant that's focused on pragmatic clinical trials in the dementia space. And we created the data that I've just been talking about. We took 100% Medicare, applied the algorithm we're talking about, and then we created a lot of data, state, hospital referral region, hospital service area, primary care service areas to be useful for informing pragmatic clinical trials, but we also learn a lot otherwise. So what I'm going to talk about now, and I know I'm talking so fast, sorry, but I will keep plugging along here. First is I want to talk about some of the understanding around racial differences in diagnosed prevalence, just to not to answer why, but just to give you some data facts, some numbers to sort of hang your head on. So what percent of people within these racial groups have diagnosed dementia in our claims data? This is we're always thinking about what's the denominator. This is among people who are Black, what percent in the 65 and older in fee-for-service Medicare have a claim for dementia, and it's 8.5%. Among the Hispanic enrollees, it's 7.2%. Among whites, it's 6.1%. So this is when people tell you Blacks are at higher risk, they get this disease more, that's what this is reflecting. Okay. I'm flipping the denominators around on you. Say what percent of people with ADRD in Medicare, so you take everybody who has ADRD, and what percent are in each of these groups? I'm just going to focus on Black here. 10% of the ADRD population is Black. I'm now showing you all people in Medicare, not just ADRD, and only 7% are Black. So we're seeing an overrepresentation of people who are Black in people diagnosed with dementia. Again, getting at that higher risk is being reflected in the claims. Okay, so now we're going to go on to Nuance. I'm hoping I haven't lost you all. This is really important. We're talking about regional variation. What this map shows, this isn't actually dementia at all. This just shows the percent of Medicare beneficiaries in fee-for-service who are white, according to Medicare claims, by hospital referral region. Okay, it looks like a north-south thing. But if I asked you, okay, so what are those lower states? What is that really composed of, and is it uniform? Here's the percent that's Hispanic. And here's the percent that's Black. Why am I making a big deal about this? Because if you use a variable in your model that says Black, it is not representing just Black. It is representing, you're doing a national study, it is representing a certain geography of the United States. And I think sometimes that's the nuance of doing this work and the importance of geography when we're talking about healthcare and health policy, that this variable that's very simple to plug into a model doesn't mean only what we think it means in a national study. It also brings lots of other things with it, including inherently overrepresentation of certain geographies. That was Nuance 1. Nuance 2. Let's talk about setting of care. First, what we're saying here is we're really focusing on emergency rooms, skilled nursing facilities, and hospitals. And we're really interested in what percent of the work they do is to serve people who have Alzheimer's disease. So those bars are showing percent of events at an emergency room that are from a person who has Alzheimer's disease or related dementias. The first point, and we don't even have to look at every, you can just look at the first one. We're looking at emergency departments, hospitals, and skilled nursing facilities. First, number one, emergency departments and Medicare. There's a lot of dementia patients doing this getting served in these settings, right? This is skilled rehab, hospitals, and emergency rooms. From 15 to almost 50% of the people they serve have this diagnosis. The other important part is when we go across the right, we've stratified this by small town, town size, hospital size, whether they're teaching or non-teaching, and those make very little difference. So the bottom line here is people with dementia are everywhere. It's not a rural problem, it's not an urban problem, it's not a teaching problem, it is everywhere. But if you're doing a study and you're going to say, we see studies on validating the diagnosis of dementia in claims done in hospital records, right? If you only look at hospital records, you have a much higher prevalence of this disease than you would in a community sample. So your estimate of the accuracy of your diagnosis and claims is going to be very different unless you're doing it in another place. So that's a really serious nuance, but the bottom line is these patients are everywhere. And when you're doing setting-specific studies, you need to be cognizant of what proportion of that service is these people. Let's talk about nursing homes, another nuance. People will know that if you're studying nursing homes, there's a very high percentage of people who have cognitive impairment dementia. That's what the boxes are to the left. But what people forget from the population perspective is if you're using claims data and you're identifying people with dementia, what percent of those people are going to be in nursing homes? Because it's not obvious in the claims data. There's no easy flag that says, hey, this is a nursing home resident. You have to create that. So this data is actually using the health and retirement study, which is nationally represented. We say if we take all these people in 2012 who are in fee-for-service Medicare, take all the participants in HRS linked to claims, what percent reside in a nursing home? 3.5%. If you take everybody that the HRS says has dementia, 21% are residing in a nursing home. Okay, so very high proportion. If you use claims data alone, use the standard 1-year algorithm, 33% are living in a nursing home. So many of us use standalone Medicare claims data with nothing linked and don't pay attention to whether they're in a nursing home. But if you're studying anything about healthcare delivery and outcomes, this is a major confounding that we're likely not taking into account, or bias, or however you want to determine however your study design works, because we tend to forget that these things go together, having dementia and being in a nursing home. This is just, you look at these two maps, don't even look at the words. They look the same, right? They look pretty similar. So the map on the right is the percent of people, a percent of ADRD cases in long-stay nursing homes. The map on the right is the number of beds in nursing homes for different states. Again, showing this issue, there's something driving the percent of people we see in nursing homes in claims. That's not about people with end-stage disease of dementia. It's probably about the supply of nursing home beds in that setting where a larger proportion are there. Again, that's definitely a nuance, but a reminder of thinking about how the health system and policy influences what we see in claims data. A few words about MA. Medicare Advantage and Medicare, traditional Medicare. There's some people in our group, in our CAPRA family who don't use claims data and may not know the difference between traditional or fee-for-service Medicare and Medicare Advantage. So we're going to go a little bit over that because this is really important. Historically, first of all, we've only had data in traditional Medicare. It's only been in the last 5 years that we've had data in actually longer than 5 years, in Medicare Advantage. The difference is in fee-for-service, or traditional Medicare as it's now called, when I go to a doctor, they see me, they submit a bill, they get reimbursed for that service. Medicare Advantage is managed care. Whoever takes care of me is paid a lump sum of money to take care of me over that year, whether I use the service or not. That's the sort of most basic difference. So there's really importance in things in what we see in the data. So what's reflected in the data for MA are what's called encounters. It's not an actual bill. It's acknowledging that something happened and it has a lot of the same elements as the claim in Medicare. But it's not actually a bill, it's an encounter. So that says something possibly about accuracy and validity of what's in those encounters. So that's point number one. The other thing is Medicare Advantage gets risk-adjusted payments based on how sick their population is. So what does that do to their likelihood of billing a diagnosis? Or how hard they're going to look for diagnoses? It increases it. So there's a financial incentive to get diagnosed more people. Okay, so let's look at just some data here. This is 2019 data. It's actually changed dramatically since then. But across the United States, this is not dementia specific. This is the percent of Medicare beneficiaries 65 and older enrolled in Medicare Advantage. At that time, overall, it was about 37%. We split out partial year. Those are people who are shifting, so they basically have both MA and fee-for-service in the same year. That number has continued to increase. What people will say today, it's about 50% across the country. But again, now you guys are savvy. When people say it's 40% or 50% of people are MA, it matters where you are. It matters where you live. Look at this map, right? There's places at this time that was 0 to 20%. There are places where it's almost 50% at this point in time. So again, place matters. And these, if you do an MA study, you will represent certain parts of the country and not others. Let me show you a little bit about some trends over time. This figure is going from 2018 through 2021. This is taking the traditional Medicare and the Medicare Advantage and putting them together. So we're not looking at just half of the picture. We're looking at the whole picture of all of Medicare. The yellow bar is the percent of the dementia beneficiaries who are enrolled in traditional Medicare. The blue bars are those enrolled in MA. You can see it's increasing over time while the fee-for-service is declining. The line graphs are showing you the number. So we're getting to near parity in 2021. One of the things I want to stress here is that while I think we all hear the message, we really need to focus on MA because it's really, really growing importance, traditional Medicare is still important. Half the people are still in traditional Medicare. So we really can't lose sight of that ball when we're doing our studies. And I would advocate we should be moving toward to studying these two sets of claims, these two sets of payers together as the total population of Medicare. This is just another interesting question we asked. We're almost done here. We were really curious about what happened during COVID in MA compared to fee-for-service. So these are data we thought were pretty hard. We knew that the death data in the Medicare was well established. The bottom lines with the triangles is the general population, and that's the percent of people who died. And you can't really see it because of scale, but it does go up a tad in 2020. When you look at the circles, that's the Alzheimer's population. You see, first of all, the percent mortality is very high, right? 1 year mortality for a claims-based core is about 20 to 25%, depending on if you're looking at MA or fee-for-service. MA is purple, fee-for-service is blue, gray is the combined total population. And we did see a substantial bump during COVID, which as of 2021 had not come down back to baseline yet. So an important message about couple of important messages here is, this population really is vulnerable and was vulnerable in this period. Their overall mortality is much higher, but interesting, mortality in MA is lower. So why might that be? They're thinking, oh, they do better quality, right? Is that what it is? Maybe, but Edward knows they also serve a different population in two ways. One way is that you have to opt in and enroll in this, and there can be reasons why people wouldn't do that. Like, I'm sick, I don't want to have limits on who I can see. So there's the sort of selection into MA. And then there's also what happens on the backside. When people get sick or need a nursing home, do they stay in MA? And the answer to that is often no. So let's be thoughtful when we see lower mortality about what drives that, and don't jump only to the clinical answer because there are other things driving these effects, which is the bottom line of this whole talk. So those are all the nuances I was going to talk about. I know I've talked a long time. I want to have three more slides here about access to the data for people who are new to this space. There are two ways to get access to this data. The first way, that is the way that's been in existence for a long time, is to go through the Centers for Medicare and Medicaid Services. This is standalone Medicare data. It's not linked to anything at an individual level. It can't be linked to anything else at an individual level. You can link things like regional variables and things like that. So it's drawn from the full population of Medicare. You can get it through you can physically purchase the data, or you can get it through the Enclave. There's a big hubbub recently because they wanted everybody to go to Enclave. That probably will still happen, in my opinion. It just is put off. This is the one you apply through what's called ResDAC at the University of Minnesota, and it's reviewed by the CMS itself, has its own privacy board. So this is the one I've used most of my career, and we use the VRDC exclusively, which is their Enclave. Now, there's a second way to get it, which is specific to the National Institute of Aging Studies. It's called the Linkage Program. And what this is, NIA has a group of studies, mostly it's their longitudinal cohort studies, that have been linked to Medicare claims, and they've pulled this all together through this one portal. That's the NIA Linkage Program. So in this data set, it's not everybody in Medicare, it's study participants linked to their CMS data. It's Enclave only. You have to apply for use to both the parent study and to linkage, and it goes to the NIA Privacy Board. So our group has I'm smiling at some people in the room. We have some real experience with doing these data use agreements. It's a lot. And I hope, it'll get cleaner and clearer because they are upgrading the system. But it's really an incredible opportunity. This is the list of the current studies that are already in linkage. So we're all familiar with NHATS and Health and Retirement Study and the RUSH studies, but we'll see the National Dementia Workforce and lots of other studies are already linked to the Medicare claims. Okay, so the summary is really here. Medicare data is available for nearly all people age 65 and older in the United States. That's its strength. They're uniform, good data structure. There's a lot of nuance in understanding who we see in these data relative to the true disease population. And we really need to think carefully about financial and other aspects of medical care and health policy that influence what we actually observe in the data. And I think this opportunity to use the linkage of data with directly observed cognitive status has been a great boon for the field, and I'm excited to continue to use that more. Slide of gratitude, the team, the CAPRA leads, and calling out the sort of other main collaborators on the published studies. So I will stop there, and I want to thank everybody online for joining us, and we're going to have a period of discussion and questions. Thanks.